Hi guys, my name is Charles and I'm one of the surgeons at Southpaws. Today, or this evening, we are going to be doing a live stream lecture. We were supposed to be doing a Rivoli lecture, but because of the COVID-19 issue, we've decided to go into a live stream format instead. And so I hope everybody can hear me. This is the first time I've done this type of lecture and live stream, and the technology is a little bit different. Can I just have a confirmation, please, from somebody that the audio is okay? And until we get an audio response, we'll go ahead and keep going. So first up tonight is Ben, and Ben is a surgeon that graduated from university, or Melbourne University in 2009, and we've kind of been in touch back and forth throughout his whole career. My wife, Kate Savage, who's a equine internal medicine specialist, actually was his reference for his internship in equine medicine at, or rotating internship.
Equine neonatal ICU.
Right, at University of Pennsylvania in the United States, which is one of the most prestigious locations that you could possibly do a neonatal internship, as far as I'm aware. That's
places.
Yeah. So it's kind of top of the pack there, and so then, and Ben, I think, had the intention of specializing in equine medicine or surgery, and then found out that he was allergic to horses and so, and had to end up leaving that internship, and so he went into practice in Melbourne and worked at a referral, or at a general practice that's about an hour and a half from here. And we heard from him a bit during that time period. I think he referred some cases over and stuff. And then next thing we knew, he was in the UK at the Royal Veterinary College doing another internship. To start with.
Rotating internship.
Yep.
And then followed that on with the 3 residency programs.
Yeah, so surgical residency at Royal Veterinary College, and then took his surgery boards, and we were all thrilled to hear that, probably not as thrilled as you were, to hear that he had passed. And we found out, what, about a month ago? Yep, that you had passed, and we're very fortunate to have Ben join the Southpaws team, and so that brings our number of surgeons up to 7, 5 of which are board certified, which is really exciting for us. And Ben tonight is going to do a discussion on fracture failure, and he was teasing and joking with us that he's embarrassed that he's had so many failed fractures, but if you fix fractures, they're going to fail at some point or another. And so if you meet anybody who says that they have not had any failures of their fracture repairs, and they probably haven't done a lot of fractures. So anyway, so I'm going to turn over to Ben, who will start his lecture, and then afterward I'm going to do another lecture on salivary gland extirpation in dogs, as well as total ear canal ablation. I had to take over for Chris, because unfortunately Chris Simpson had to head back over to Hong Kong due to a family emergency crisis situation, and so he's not here tonight, and I hope that I will do an okay job at replacing him. So anyway, if you have any questions or comments, you can certainly post them in the live stream, and I'll be reading them out to Ben. And so we'll go ahead and get started.
Great, thank you very much. That was a very kind introduction, and welcome to everyone to the very first Southpaws Social Distance Review Lecture series. It's a shame we can't be at the Rivoli in Melbourne, but equally it's so very nice that everyone from across the globe can tune in. So, basically, as Charles said, my sort of talk, informal lecture, discussion really, is on orthopaedics and fracture repair, and I guess the title is basically, there is a fracture and why did it fail? The lecture will be divided into 4 parts. First of all, we'll be going through bone biology and the different types of healing and how we can influence that. Then we'll be discussing fracture fixation and various implants and types and application. This evening we'll be primarily focusing on plate osteosynthesis as opposed to the other types of fracture fixation. Then we'll be touching base on the fracture patient assessment score and how, as an orthopaedic surgeon, that influences our decision making. And then I have some case examples from some anonymous colleagues that we can discuss and go through, and hopefully that will provide a little bit more clinical relevance for everyone. So going back to basics, bone healing requirements. So ultimately, there are only two criteria that need to really be satisfied for bone to actually heal. First of all, there has to be a blood supply, which sounds very obvious, but the bone is living. And more specifically with the fracture repair, there has to be preservation of the blood supply. The second aspect is that there has to be a degree of mechanical stability that allows the fracture to heal. So what we ideally need is a stabilization technique that will afford a low strain environment, and we'll get on to what exactly a low strain environment is a little bit later on. So going on to the blood supply of a fractured bone, specifically long bones here, so of the appendicular skeleton, when a fracture occurs, there's often intramedullary, the blood supply of within the medulla is often disrupted, and all of a sudden the fracture requires blood from an extraosseous source, and that generally comes from what we call the soft tissue envelope. Now the soft tissue envelope is exactly what it sounds like. It is the soft tissues that encase the fracture, and that includes the muscles, the actual muscle attachments, and any other tissues, soft tissues that have a blood supply. And it's important to realise that the quality of the blood supply is dependent of the quality of the soft tissue envelope. And I guess this may be a new concept for excuse me, for some people, but when you're considering the soft tissue envelope, you would like to consider the location. So if you think about the femur compared to the tibia or the fibula, so the femur is surrounded by musculature and hence has a very good soft tissue envelope, compared to the distal tibia and fibula, which has a very poor soft tissue envelope. And then the actual fracture type or configuration, or basically how the fracture occurred, can also influence the soft tissue envelope. For example, if there's an extremely high impact, high velocity fracture, and that will disrupt a lot of the soft tissues, and if there is soft tissue disruption, then again the soft tissue envelope will won't be as good, and hence the blood supply to your fracture won't be as good. And then you compare that to your classic green stick puppy, skeletally immature fracture, which has minimal disruption. And then finally, the surgeon can influence the soft tissue envelope, whether he or she approaches the fracture from an open technique or a closed technique. Generally, an open technique would be more invasive and will disrupt the soft tissues compared to a minimally invasive, fluoroscopic guidance technique, or potentially even an open but do not touch approach, where you open up the fracture but you don't remove any of the fracture callus or the fracture hematoma. So moving on to the mechanical stability. The stability at the exact fracture site can be considered in terms of strain, and we touched on strain just briefly before. Now, strain can be considered as the deformation at the fracture gap with respect to the size of the fracture, or in other words, the change in length of the fracture compared to the actual fracture length itself, or the gap itself. When you look at the textbooks, they will go into quite a lot of detail, and they will discuss the different types of fracture gaps, but ultimately I've tried to simplify it for you by giving you some examples. If you have a 1 millimeter fracture gap that you have repaired, and there is a 1 millimeter gap movement, then your strain is 100%. if you have a 1 millimeter fracture gap and you have 0.1 millimeter gap movement, then your strain is 10%. And again, if you have the 1 millimeter fracture gap and you have 0.01 millimeter gap movement, then the strain is 1%. So why is strain so important? Well, according to the interfragmentary strain theory, the amount of strain that you have basically dictates what type of tissue the body will produce. So if granulation tissue, which we're all familiar with, will develop and it will survive with a fracture gap level of strain at 100%, whereas you start to develop fibrocartilage or fibrous tissue or cartilage when the strain gets to around 10% or less, and then bone starts to develop when the strain levels are about 2%. Basically, small gap, there's a high strain potential. A large fracture gap, there's a low strain potential. So just summarising again, with that 1 millimeter fracture gap with 1 millimeter movement, you'll expect to get granulation tissue. If you have a 1 millimeter fracture gap with 0.1 millimeter movement, which is not very much when you think about it, you will only develop fibrocartilage. And if you have a very rigid construct, that's when you will have bone. So ultimately, if strain is not low enough, then potentially bone will not develop at all. And that's when we may see that's where we will see a fracture not healing and potentially a non-union. So when will a bone actually heal? Well, bone will only progress if there is an adequate biological and also mechanical environment, which we discussed before. So basically, strain must be around 2%, give or take, and that depends if you're trying to achieve absolute or relative stability, and the other thing that you require is a good blood supply. So you really need the quality of blood supply to be excellent, and that is, as we discussed, dependent on the soft tissue envelope. Now, I'm sure everyone can remember back to their veterinary lectures, but bone can heal in two different ways, either primarily or secondarily. And I guess it's also important to consider that different aspects of the fracture, once you have repaired it, may also undergo primary and secondary bone healing. So it really is very specific to where the strain is with that fracture. So going back to primary bone healing, this occurs when there is absolute stability. And that occurs when the strain is less than 2%. With the primary bone healing, you don't have the intermediate stages of fracture callus and fibrous tissue. They're basically not seen, which in some particular cases, like articular fractures, where you don't want a callus sort of developing and remodeling within the joint, because that would impair joint motion and potentially cause osteoarthritis. There are two types of bone healing, going back to the lecture notes: contact or gap healing. Now, trying to keep things simple and not too dry, but with contact healing, you really need a fracture gap, basically a non-existent fracture gap. So the gap between the two bones needs to be less than 0.01 millimeters. Obviously, for primary bone healing, as we discussed, strain has to be less than 2%. And if you look at the top right diagram, that is a pictorial example of contact repair. So you can see that the actual bone is extremely well reduced, and you can see the cutting cones go straight across the fracture, and followed behind it are the osteoblasts, which will then start to deposit bone. This is a very slow process compared to secondary bone healing. Similarly with gap primary bone healing, that's when the fracture is a little bit larger, the fracture gap, sorry, is a little bit larger, and you can see in the bottom right pictorial diagram that the sort of slightly darker reddish pinkish area is the fracture gap. the osteoblasts, instead of the osteoclasts, will start to deposit lamellar bone, but it will be transverse as opposed to parallel. And then once that bone is deposited, the osteoclasts will then, and the cutting cones will then come across the fracture gap, and you'll start to have remodeling as the bone heals. And again, primary bone healing is slow, but the advantage is that there isn't a callus formation. Now, when you compare that to secondary bone healing, that's when there is a relative mechanical stability. So it's not absolute, where strain is less than 2%, but it is relatively mechanically stable. So it's around about 2, 3, 4, almost up to 10%. And again, this is just a little diagram of secondary bone healing with callus formation and eventual bone remodeling. And compared to primary bone healing, secondary bone healing is actually very fast. So I guess when we talk about healing, the type of healing is actually dictated by our fracture repair, assuming everything goes well. If you have primary bone healing, you require compression and load sharing, and you can see that there's slow healing or no callus, and you can actually see a reasonably nice example in the top right series of radiographs, which is a distal radial fracture that has gone on to heal without any callus. And then with secondary fixation, that tends to be more of a bridging fixation, which we'll go on to a little bit later on. You have faster healing, but you can develop, or you will develop, a callus with the bone as it heals and remodels. Now, this is a common question that's often asked. Now, which fixation is best? And which implants are best? And I guess ultimately there are many different ways to stabilize a fracture and to ultimately achieve osteosynthesis. And there is a little bit of surgeon preference about what he or she would prefer, but I guess ultimately there are certain rules that you do need to adhere to, which we have touched base on already, which are the mechanical and biological aspects of the fracture. We'll be focusing this evening on the plate fixation osteosynthesis. Generally, they're considered a good implant to repair fractures. They are able to resist the four, main forces that you do see on fractures. They are considered weakest in bending, but also, excellent in tension or axial forces. Then there are various different types of external skeletal fixators, and then intramedullary pins, and also interlocking nails, and you can sort of see the pros and cons about each of those. I thought I'd just pop in one slide about external coaptation. The theory behind external coaptation is that the bandage actually reduces the motion of the joints above and below the fracture, which, if you're unable to bend or flex your joints, then you're unable to use your muscles or tendons, basically, and thereby that reduces the forces acting on the bones, which reduces the distraction forces acting on the fracture, which means that there would be hopefully enough stability there for the fracture to heal. But there are various reports in the literature that cite, most commonly would be soft tissue related complications, and they can vary from 40 to 80%, and sometimes these soft tissue complications can actually be worse than the fracture themselves. Generally speaking, I'd reserve external coaptation, so that's a bandage with a splint, basically, or a fiberglass cast. I generally reserve them for younger patients. You'll have biology on your side, faster healing, so you won't have to have the bandage on irritating the soft tissues for an extended period of time. It is much easier if the fractures are inherently stable, i.e. so not a comminuted fracture, and they're inherently stable when they are reduced. So before you put a external coaptation on for a fracture, you obviously should try and reduce it. It's also quite a good option to elect for external coaptation if there is an internal splint that is intact. So for example, if you have a fracture of the radius but the ulna is intact, or similarly if you have a fracture of the tibia but the fibula is intact. Then, as I mentioned before, you do ideally want to immobilize the joints above and below the fracture, but that is obviously not possible with some bones. So for example, the humerus or the femur, scapula, it's impossible to adequately mobilize those purely with external coaptation. Now with plate fixation, plates are inherently stable under tension, which I guess makes sense. If someone handed you a plate and they asked you to break it, you wouldn't think about pulling it apart like an elastic band. There's an innate intuition that the best way to break a plate would be to bend it. So we can use that to our advantage by applying the plate on the tension surface of a bone, because the plate will be mechanically stronger in that manner. The tension aspects of the femur, tibia and proximal humerus are the sort of the cranial lateral aspect, whereas the tension aspect of the radius and the ulna are the cranial and caudal aspects respectively. But as you can imagine, sometimes you just can't perform that. For example, a tibial fracture, we would commonly repair that with a medial plate as opposed to a lateral. Now with bone plate application, I'm sure some people are very familiar with this, but for those that aren't, with a lot of plates you are able to place them either in compression. So for something like a dynamic compression plate, you are able to compress the two fragments together with the plate. You can have a plate that is placed to neutralize forces, so it's a neutralization plate. For example, that could be a tibial fracture that is stabilized with some lag screws, and then once it has been anatomically reduced, you can then place the plate over the fracture to reinforce the construct and to neutralize the forces applied to the tibia. And then finally, you can place a plate in a bridging construct. So that is where there's a horrendous comminuted fracture, you're unable to anatomically reduce the fracture, and then the implant will take the majority of the load. And I do have a little diagram sort of illustrating that a little bit later on. But ultimately, whether you adopt plate osteosynthesis with compression or neutralization or bridging, it is ultimately dictated by the fracture configuration. And going on from that, in terms of the bone plates and the actual fracture type, if you have a simple transverse fracture, for example, that you are able to reconstruct, you can achieve load sharing and you can compress, and then you'll be able to achieve hopefully primary contact healing. With simple oblique fractures, often they are reconstructable. You generally can achieve load sharing, and you would try or potentially place a neutralization plate, or if you have a comminuted fracture that's non-reconstructable, then you may have to elect for a bridging fixation. So just going on to the load sharing and bridging fixation, in case that's unfamiliar for some of you, but basically with load sharing, the force that goes through the fracture repair will go through both the bone and also the implant. And you can see that quite nicely just with the diagram A. So the green line is the force, and you can see the force going through the bone and then also through the plate. So it is load sharing. The advantage of achieving load sharing is that there's less stress on the implants, and you're increasing the longevity of the implants. With a bridging construct, which is highlighted in the diagram B, basically there is no axial forces going through the long bone through the fracture. So the weight itself, if you follow the green line, is basically going through the plate. So this means that there is a higher risk of failure if your construct isn't strong enough. So ultimately it's a race, and there's always pros and cons about both. So moving on to fracture repairs, fracture repair complications, I guess if the fracture fixation is inappropriate, then you can have implant failure. We won't go too much into the next sort of 4 things, but you have delayed unions, non-unions, malunions. Potentially can lead to infections or osteomyelitis, and if you have a malunion that is incompatible with normal function, then you can have a chronic mechanical lameness as well. So without making it too dry, when you look at implants, basically if they are subjected to a force that is too high, ultimately any implant will fail. And then as orthopaedic surgeons, when you look at the particular material or structures, these can be assessed with what we call a stress strain curve. And don't worry, we won't get into too much detail with that. But in orthopaedics, veterinary, human, we tend to deal with the initial linear portion of the curve, which you can see in the bottom left, which is roughly where that blue right angle triangle is. And then 2, I think, key points that should be emphasised are what we call elastic deformation and plastic deformation. Now, elastic deformation is the ability of the implant to return to its normal shape after a load has been applied. So a classic example is an elastic band. As you stretch it, there's elastic deformation. As you let it go, it will return to its normal shape. And with all implants, stainless steel plates, you do have a degree of elastic deformation.
Ben, can I?
Yeah, of course.
Just interrupt. There was a question on the previous slide. It looked like maybe one more. Go back another one. Why there was only one cortex engaged with the screws that were adjacent to the fracture. So here and here there was only one cortex engaged. Why was that?
That's a very good question. I have to be honest. I'm not 100% certain. If I was actually doing that fracture, I would have placed them bicortical.
Yeah. Great. Sorry.
I think it was more the illustrator's tendency just to draw monocortical and bicortical screws. But yeah, I think most people would try and achieve bicortical screws there. Sorry. And then I think we were discussing that plastic deformation, that's when you have permanent deformation. So you classically see that actually intra-operatively when you're contouring a plate. When you're contouring the plate, you're bending it, you're permanently bending it, and that is what we call plastic deformation, and that occurs at the yield point on the stress strain curve. And I guess it's also good to know that if you are contouring a plate, you are subjecting to plastic deformation, but when you start to do that multiple times, your implant will weaken. So try not to contour it too much, so backwards and forwards motion. The implant shape and the actual material itself can also influence the strength of the construct and hence how the fracture repairs. The shape of the implant, which we'll often describe as sort of the area moment of inertia, will influence how strong the implant is. And an example of that is if you have a plate, you would bend it sort of conventionally as opposed to trying to bend it on the edge, if that makes sense. Then the material itself that will thank you, Charles. Then the material itself that will also alter or influence the fracture repairs. So they talk about Young's modulus, which is the linear portion of the stress strain curve, and ideally you'd like to pick a material that is fairly similar to basically the viscoelastic properties of bone. So you want to choose a material that's quite similar to bone, and some of the more common implants that we'd use are 316L stainless steel and titanium, but I guess another factor that we have to consider is the cost of the implant. Obviously titanium being much more expensive and in some circumstances not doesn't give us a major advantage compared to steel. Now just briefly touching on malunions and non-unions. Malunion refers to a fracture that has healed completely but with an abnormal conformation of the bone. And then with malunions you can have functional or non-functional. They can be non-functional or functional. So you can see this little kitten here has got a malunion causing varus and internal rotation, however was still able to walk relatively well. Now non-unions, this is where you can have, there are various different types, and again we won't get into too much detail, we'll try and simplify things, but you can have a delayed union, so that is radiographically, it's basically the progression of fracture healing is slower than expected, but the fracture will hopefully progress to a union. So you expect a delayed union to progress to complete bone union. Whereas a non-union, sorry about the spelling mistake, is not expected to heal without further intervention. And I guess it's interesting to think that all non-unions would have one stage satisfied the criteria of a delayed union. Now with the non-unions, I think if we just kept it simple, basically there are viable and non-viable unions, and the viable unions, the reason why I've got a elephant's foot there, the hypertrophic viable union, not viable non-union is quite commonly seen when there isn't enough mechanical stability and the bone really flares out as it tries to reduce strain at the fracture gap, and it tends to look in some people's eyes as an elephant's foot. Now the next part of the talk, which I think is really important more in a clinical setting and hopefully more relevant for all of us, is the fracture patient assessment score. So basically every fracture is different, every patient is different, and every client is different. Before you undertake a fracture repair, it's good to evaluate the patient, the actual fracture, and the client, and to actually come up with a fracture patient assessment score. Now there's no actual numerical or grading system, but ideally you'd have good, moderate, or poor. And then the three factors that you really do need to consider are the mechanical aspects, the biological aspects, and the clinical side of things. So with the mechanical forces, I guess this is when you're sitting in front of your radiographs and you're thinking about what type of fracture is it, what forces are there, and what implants should I be considering to repair this fracture. Now when you're thinking about it, you really should look at the inherent stability. So is it a transverse fracture that you're able to reduce and compress, or is it a comminuted fracture that you cannot reduce and there's inherent instability? Is it reconstructible? Is the patient extremely obese dog that struggles to get up, and there's going to be more force going through your construct? How active is the patient? Is it a agility dog? Is it a working dog? Or is it quite a sedentary cat? Exactly. Thank you, Charles. And then another big one that will often cause problems is, are there actually other injuries to the patient? Often we see cats and dogs that are hit by cars. Do they have multiple fractures? Is it just the one fracture? So these are the mechanical sides of things that we need to consider, because ultimately your fracture repair has to neutralize the disruptive forces, and how stable or unstable or how much weight the patient will put through the fracture will determine how much force you need to neutralize. So if there are lots of negative mechanical fractures, if you deem the fracture as being poor from a mechanical point of view, then you will require a stronger construct. So you'd be thinking, do I need more implants? Should I be factoring in the size, the shape, the area moment of inertia of the implants, or the actual material itself? So moving on to the biological aspects of the patient assessment score. This is looking at the health of the patient and I guess the healing potential of the fracture. So often we'll have a look at whether the patient is skeletally immature. Is it a puppy, a kitten? Generally they'll have the healing machines and they'll have fantastic healing potential. Or if it's an older patient that is on various medications, for example, will that or is systemically unwell, that may reduce the healing potential of the fracture. And then often we'll have a look at fracture location, or the potentially, if it is traumatic, the presence of infection or even cancer. If there is poor fracture biology, usually this will result in slower fracture healing. And I guess another example is consider a healthy puppy versus a geriatric cat with endocrine disease. If the biology is poor, then obviously it's going to be slower. That means that your fracture fixation technique needs to be more durable, needs to go the distance. And then finally, the clinical or the client side of things, tend to look at the post-operative compliance. So what's the temperament of the patient? Will they easily be rested post-operatively, or are they outside? They won't be looked at. There are various aspects that you will need to consider. So you may increase the rigidity of your construct, or maybe not elect to go down an external skeletal fixator path if they're just going to be outside and not monitored. So in terms of the approach to a fracture repair, once you have looked at the x-rays and decided on your fracture score, I guess then you can choose to perform either a mechanical approach to osteosynthesis, and that's where you try and achieve primary bone healing, whether that is gap or contact, or you can elect a biological approach to osteosynthesis, and that's where you would elect to try and achieve secondary bone healing. I guess the important thing is, once you have decided, you should be committed. So the worst thing that you can do is attempt, for example, a mechanical approach, or attempt for primary bone healing. So you try and attempt to reconstruct the fracture. You then disrupt the soft tissue envelope, and then invariably it does happen, but you're unable to repair the fracture adequately, and then you elect for a biological approach. And the problem with that being is that you have disrupted the fracture hematoma, you've disrupted the soft tissue envelope, so potentially setting yourself up for failure. And as we were alluding to, there's always a balance between the mechanics and the biology, and as we previously touched on, it is dictated by the fracture type. So whether it's reconstructible, you can achieve load sharing, which is advantageous as you can decrease the risk of cyclical loading and subsequent failure. But to achieve that, you do need open reduction, aggressive dissection, and disruption of the fracture biology. Where if it's non-reconstructible, you're aiming to maintain fracture biology. So you can achieve that via minimally invasive plate or nail osteosynthesis, or taking an open but do not touch approach. But the big concept is, if you have taken a non-reconstructable approach, don't try and do that from the start. Now, with all that in mind, before we get into our cases, I guess ultimately the goals of fracture repair are fairly obvious, but the AO principles are that there should be anatomical reduction of the fracture fragments and restoration of the limb alignment. Ideally, you want to preserve blood supply and bone fragments, blood supply to the bone fragments and soft tissue envelope, and then you want to stabilize the fixation, sort of satisfying the biomechanical requirements, and also the ultimate goal is to achieve early pain-free movement and weight bearing. So we have got 4 clinical cases now, and with each of them we'll briefly touch on the fracture patient assessment score. Then we'll critique the post-operative fracture repair. We could identify any errors if they're applicable, and sort of overall outcome. But before we go into that, were there any other questions? Oh, fantastic.
Yeah.
Thank you. So our first case is Sally, who is a 5-year-old female neutered terrier cross. She was in a road trauma accident and sustained a tibial and fibular fracture. It is comminuted mid-diaphyseal. There's some displacement and overriding of the tibia, and obviously the fibula is fractured as well. When we have a look at the Sally's assessment or fracture patient assessment score, in terms of the mechanical, you'd say that she's moderate. It's potentially reconstructable, but even if you can do it, should you do it? With this type of fracture, it's inherently unstable to all forces, so there's no load sharing that's able to be achieved unless you can reconstruct it. Some good things are that even though she was involved in a traumatic accident, only one limb is affected, and she's a small dog. She's got a huge Great Dane that's 80 kilograms, that's going to put a lot of force through this bone. In terms of the biology of the fracture, I'd say it's moderate as well. So she's mature, so not mature meaning not skeletally immature. She's systemically very healthy. She's got no other comorbidities. When you look at the tibia, it does have a poor soft tissue envelope, so there are the muscles on the craniolateral aspect, but it's not all encompassing, and this fracture was closed, so there's no signs of infection. So biologically it's not too bad, it's a moderate. Sally's owner was lovely, and Sally was very compliant. She wasn't going to be too silly. So overall, mechanically moderate, biologically moderate, and the clinical aspects are good. As you can see, it is quite subjective, but it's important to, in your mind as the orthopaedic surgeon, to have a rough idea, because this will dictate what you do. So Sally's tibia was repaired via a medial plate, elected to perform a bridging fixation. So you can see that the fracture itself, there was no attempt to reconstruct that fracture in any way. The type of implant that was used was a Fixation plate, which is an Italian locking plate. If you're being critical, you'd say that the distal 2 screws might be a little bit too close to the fracture / potentially in the fracture, but overall in terms of the alignment and reduction, you'd be pleased with that. And then as we look at the I think it was about 6 weeks, and then it was about 10 weeks after that, you can gradually see that the sort of the secondary bone healing is occurring, and that in the later radiographs you are starting to get that hard bony callus. So that was a good success story. Case number.
When I saw that case and you were putting it up, and I saw the way that you had repaired it,
I thought you were going to say that was one of your failures, and I thought that is such a great repair. If that failed, I don't know how else you could have done it. So I'm glad to see that it was actually successful.
I thought we'd start off with a good one. The next one is Daisy. Now Daisy was a 1-year-old or femur-needed poodle. She again was in a road trauma accident, and she had what we've all seen before, a distal, radial and ulnar fracture. If you were classifying it, it would be basically simple transverse, maybe short, oblique. It's closed, there's some overriding and malalignment as you'd expect. But from a mechanical point of view, is it reconstructible? Yes, it is. Are you able to achieve load sharing? Yes, because you are able to reconstruct it. Is it inherently stable to some forces? Yes, it is. It would be stable against compression. And a single limb was affected as opposed to multiple limbs, which is also advantageous. When you look at the biology of this fracture, well, Daisy is skeletally mature. Yes, she's systemically healthy. When you look at the radius and the ulnar, it doesn't have a great soft tissue envelope, and generally has is regarded as having a very poor blood supply. And generally, the distal radial fractures of small breed dogs can be extremely challenging fractures to manage. And then again, Daisy was very compliant, or very well behaved, and the owner compliance was excellent. So this was repaired with a plate, and generally you'd be happy with the alignment and the positioning of the implants. They may look a little bit long, but they're not interfering with the ulnar in any way. They're bicortical. There's you're maintaining the procavatum of the radius, but when you look a little bit closer, there are some potential problems with Daisy's fracture repair. If you can see where the blue arrow is, there is a gap at the transcortex, and that the fracture itself is very close to the hole. These particular plates, they have a solid metal part of the plate, and ideally that should be directly over the fracture. So the big concern that we have with this particular fracture is that there is no load sharing, and as you can see with the pictorial diagram, that if you have a defect on the transcortex, it does make the fracture inherently weak to particularly bending forces in this distal radial fracture. And as we know from our diagram before, that plates are notoriously poor at combating bending forces. So Daisy had a fantastic recovery for the first 3 weeks, but she ultimately did fracture the plate, and you can see that with the 2 left radiographs. You can see that the fracture has occurred, not surprisingly, at the level of the fracture, and it has fractured straight through that hole and through the screw. It was later repaired with a similar plate, and they elected to increase the construct and rigidity of the fracture repair by adding by performing coaxial plating, and another plate was placed adjacent to that. However, you could argue that there still is a small fracture gap on the transcortex, and also you'd be worried about the biology of this fracture, given that it has been so long and it hasn't completely healed. So unfortunately, 4 weeks after this fracture, the implants failed again, and you can see that again it went straight through the fracture hole, which is considered one of the weaker parts of the plate. So following on from this, poor Daisy had a second revision surgery and had much stronger implants placed, again with biaxial plating, and fortunately for Daisy, this went on to heal very nicely. Our next case is Oliver, who was, it always happens to the nice ones, but one of the nicest 6-year-old domestic short-haired cats that you'll ever meet. He came off second best with a car and had both a really nasty comminuted segmental tibial fracture that you can see on the left 2 radiographs, and also had a proximal ulnar fracture with a radial head dislocation, which also known as a Monteggia fracture. And for those sort of sitting for boards or studying, it's a type 1, so it's a proximal ulnar fracture with cranial displacement of the radial head. Now, when we are, and apologies, the markers aren't included on this, but they are both on the same side, so it's both on the right thoracic limb and the right pelvic limb. So when we assess Oliver, I guess we can look at first of all, the tibial fracture. And from a mechanical point of view, I think everyone would agree with me that it'd be very poor. It's comminuted, you can't reconstruct it, hence you are unable to achieve load sharing. The fibula has a segmental fracture, so that's not intact, so it won't act as an internal splint. There's polytrauma, so there's another limb that's involved. And then when you look at the thoracic limb with the Monteggia fracture, you'd say that even though it's a very nasty fracture, probably is more of a moderate from a mechanical point of view. It is comminuted, however, but you will be able to achieve some load sharing when you reduce the radius. So when you'll be able to, through the humeroradial joint, at least be able to achieve some form of load sharing. It is more challenging as it is a articular fracture. And when the radial head luxates like that, you will have disruption of a lot of the collateral ligaments. So with this particular fracture, and we'll have a look at the postoperative radiographs, with this particular fracture, you will require also some prosthetic ligament repair as well. But with this, you will be able to achieve load sharing to a certain degree, and I guess the difficult thing with the elbow is that there are a lot of different forces acting on it. From a biologic point of view, you'd say that it is moderate to poor when you factor in both fractures. Some would say that the feline tibia is the equivalent of the small dog distal tibia, that the blood supply is quite poor. With Oliver, he's skeletally mature, he's systemically healthy, but in both of those fractures there is a poor soft tissue envelope, so the blood supply isn't as good, for example, as the femur. And both fractures were closed, and as I said, Oliver was a lovely patient, or is a lovely patient. So with these are the immediate post-ops. With the tibial repair, we tried to just lasso / reconstruct or partially reconstruct the tibia, just because it was so severely displaced and comminuted, and then tried to neutralize that with a locking compression plate just placed in neutral. And then with the Monteggia fracture, an ulnar plate was placed, and you can see at the level of the ulnar trochlea there's a crimp there, which was where the prosthetic sutures for the humeroradial repair were. Of interest, the fragment that you can see just cranial to the distal humerus is the coronoid process, where the annular ligament attaches to, and that was avulsed. We spent a good 10 minutes trying to find that, but eventually gave up. So Oliver made a good recovery, and at 4 weeks the owner was quite concerned and wanted to come in for radiographs. at 4 weeks we wouldn't really expect anything to have happened, but when we compared these radiographs, which are the 4 weeks post-op radiographs, compared to the immediate post-ops, everything looked fantastic. We were obviously very pleased with ourselves, and Oliver went home, only to return a week later due to a wonky leg. Now, Oliver hadn't been running or jumping or climbing or playing, but the owners had, and wasn't overly painful in any way, but the owners have noticed that his leg was just sticking out laterally at a funny angle. And what we can say about this, if we go back to the sort of that stress strain curve, this plate has undergone plastic deformation, so the plate is now permanently bent, but I guess it actually hasn't fractured, if that makes sense. So this is a form of implant failure. So this particular fracture was revised, and 2 biaxial plating was performed because the mechanics and the biology, I guess I personally underestimated how sort of the cyclical loading going through there. We did have implant failure, and then I don't have the most recent ones, but the 2 radiographs on the right do show that there is starting to have some bone remodeling, and I'm told that Oliver's still doing very well. Now, our last case is an 8-week-old moggy cat that sustained a mid to distal third diaphyseal fracture of the femur. This is quite a difficult fracture, and I apologise, I don't actually have the fracture patient assessment score, but from a biological point of view, having an 8-week-old cat, the biology is absolutely fantastic. They're healing machines at this age. In terms of the soft tissue envelope, it's of the femur, so there's excellent musculature all around. From a mechanical point of view, it's not comminuted. It is quite slightly oblique, but it isn't comminuted, and it should be able to achieve some form of load sharing. Overall, you'd say that's moderate from a mechanical point of view, and excellent from a biological view, and at least cats are more easy to restrain post-operatively. They're more amenable to crate confinement. So this cat had what we call attempted rush pins place. As you can see, it was so small and so fiddly, and the bones were just so soft that it was quite difficult to achieve perfect reduction. You can see that the proximal fragment is caudally displaced, and there is some overriding. In case people aren't familiar with rush pins, the idea is to place, it's slightly different to cross pinning, where you would pass the pins through 2 cortices. With the rush pins, you aim to proximally touch the pins up against the inner cortex, and that will provide sort of another point of contact. And generally they're reserved for sort of skeletally immature patients that have fantastic biology. So initially we're a bit concerned about whether this would heal, but then Ozzy did fantastically well 4 weeks post-operatively. You can just see the powers of a biological approach to osteosynthesis, and you can see how there is basically radiographic union of the bone, and then you can also see a lot of bone remodeling. And the advantage of the rush pin is that it doesn't interfere with the growth plates. So if you compare it to the pre-ops to the post-ops, just where the proximal aspect of the rush pins are, you can actually see that the femur is elongated nicely. So that was a nice little success story for little Ozzy. So I guess summarising, that's the end of our sort of clinical cases, but summarising with fracture repair, I guess it's absolutely critical to try and preserve your blood supply and adhering to Holstead principles and just knowing your approaches to minimise soft tissue disruption is critical. For actual bone to develop, you need to create a low strain environment, and whether that is via absolute or sort of secondary bone healing, it should be around 2%. And then whenever you see a fracture, remember that the fracture, the circumstances and the patients are different, so we should have a fracture patient assessment score which looks at both the mechanical and biological and also the clinical factors. So I'd just like to thank a couple of my colleagues in the UK and in Spain, and if there are any other questions, happy to field them, but I've been noticing Charles is furiously typing, so hopefully answering any of the more difficult ones.
I think I've answered most of them, although I have been making a few jokes as well. So.
Oh, great. Perfect.
Not at your expense. All right, so I'll go ahead and take over. You've got a 4-year-old daughter, so you go home.
Oh.
Yeah.
Thank you very much,
so
everyone.
I'm sending Ben home because he has a young daughter, and so I will take over, and I just need to set up for a minute and get my iPad out here and juggle the video stream a
Just in
minute.
Charles?
I don't need, that's
don't
right,
need it.
no,
Oh,
all good, thank you. And then I'll switch over to that, see how that works. And wake up my iPad and see a picture of my puppy. Just make sure everything's still plugged in there. That's all good. Okay, let's see if I am set up here. Alright, so we are back. Alright, so hopefully everything's working. Get my pen out. And Ben, again, we've sent home. He has a 4-year-old daughter at home, so no reason for him to stick around here and help me out. But thank you very much for the welcome. Hi, Payush, how's it going? I'll try to keep it brief and interesting. I'll switch over to the lecture side of things. Let's see here. Sorry. That should be working there. 3, cut, and then see what's going on here. Sorry guys, just need a minute. Hopefully my face will appear in the corner. And I'll hit play. All right, so the first thing that I wanted to mention is that the topics that I'm giving, which are salivary gland extirpation and total ear canal ablation, were supposed to be part of a lecture series that I was doing with VetPrac in Gatton, and sadly that wet lab was cancelled because of COVID-19, and that was supposed to have taken place at the end of May, I believe it was, and so that was cancelled. It's been moved to October, and I asked Margie McEwen, who owns VetPrac now, if I could use my lecture tonight from that VetPrac seminar, and she said that that was fine. Also, just want to let you know that when we do this wet lab, that'll be October 2nd through the 4th, I'll be presenting the same topics, but we also have a wet lab associated with it. So it's a 3-day program, and they're just amazing. There are usually 32 vets that come. Everybody has dinner together, lunch together, breakfast together, and we do some lectures. Probably about half the time is spent in lecture and half the time is spent in the laboratory, actually learning how to do the procedures. And I spend a lot of time doing anatomy and that kind of thing. And so I wasn't sure how to create a link that you guys could click on, but I'll try to add that later on to the lecture. If you can point your phone at the computer screen right now, and put it on the camera on your telephone, the QR code should register to a registration page for the conference. And so the conference is from the 2nd to the 4th of October in Gatton. I'm going to talk to you today about the surgical treatment of severe otitis externa. And indications for surgery would be basically otitis externa that's refractory to medical management. And so you guys would know much more than I would about medical management of otitis externa, but I will, because you guys would manage it a lot more than I would, but I do know that these patients that come in have been on very appropriate antibiotic therapy and sometimes corticosteroids and that kind of thing, and they still have really nasty otitis externa. So, and then the other indication would be neoplasia of the ear canal, and the most common one that we see is ceruminous gland adenocarcinoma. Occasionally we see squamous cell carcinoma as well. So I'm just going to have a look over here. Question about the quality of the image. Has it dropped terribly? Same quality here. Let me just... no, everything looks good as far as I can tell. I'll just enlarge the screen here and see what the image looks like. No, it looks fine at my end. The other thing that can happen, guys, is that YouTube is throttling the speed sometimes of the connection because of isolation. There are so many people that are trying to use the internet at the same time, so they've actually slowed down or reduced the image quality on YouTube, and so you may have to go in and change your settings at the bottom. I'll just go down to my phone and have a look and see if let's see here. I'm going to go into YouTube and see what the quality of the, let's see. Now, when I look at my phone, the quality is great. And so I would look at your stream and see if the quality has dropped off HD. Anyway, so I'll just keep going here. So one procedure that you can do for otitis externa that's refractory to medical management is a lateral ear resection. And basically what you're doing is you're taking off the lateral wall of the ear canal, just making it so that basically air can get in. It's a little bit easier to medicate. And it changes the microenvironment of the ear by allowing air to get in there and decreasing the humidity. The problem is that there's a failure in about 55% of cases, and I've had to go back in. I have had to go back in and do total ear canal ablations on these patients that had already had lateral ear resections in the US in a lot of cases. Lateral ear resection fails in about 83% of Cocker Spaniels, and note that that is American Cocker Spaniels. And since I came to Australia 16 years ago, I find that Australian Cocker Spaniels have much better ears than American Cocker Spaniels. And so I used to do sometimes 2-3 total ear canal ablations a day in the US, whereas in Australia, I probably do one every couple of months. So I think that either Australian vets are better at managing otitis externa in dogs, or that Cocker Spaniels actually have better ears in Australia than they do in America. Note also that when you do a lateral ear resection, that medical management is still required in these patients. So basically what we're doing is we're making 2 incisions that are parallel on either side of the ear canal and creating a drain board down here. So we've resected a rectangle of skin here. We're creating a drain board down here, which is going to allow us better access to the ear so that we can clean it more effectively, decreasing the humidity in the ear, and potentially making it easier to clean the ear. So, look, lateral ear resection may be effective in some patients, and I'd be interested in other people's comments if they have found lateral ear resections to be very successful, moderately successful, or not very successful. And please put your comments in the live chat as to what your success has been in the management of otitis externa using lateral ear resection. Now we'll move on to total ear canal ablation and lateral bull osteotomy. So the indications for TECA or TECA LBO would be irreversible ear canal disease. So if you had really severe hyperplastic epithelium in there, stenosis of the ear canal, oral trauma. We've had a couple of cases where they've had dog bites to the top of the head, basically avulses the ear canal from at the level of the bulla. Ear canal neoplasia, as we had discussed, ceruminous gland adenocarcinomas, sometimes congenital malformations. And interestingly, with ceruminous gland adenocarcinoma of the ear canal, when you do a total ear canal ablation, the median survival time is 4 years. And when you do a lateral ear resection, the median survival time is only about 1.5 years. So definitely indicated to do a total ear canal ablation when you have a ceruminous gland adenocarcinoma of the ear canal. So I'm looking at the comments here. Some people saying not very helpful. John is saying done quite a few laterals and almost always have been successful. Most successful large breed dogs, as you guys can read as well as I can. Andy says very poor success rate, moderate success, but careful patient selection, and comment that I prefer TECA over lateral ear resection. Lateral ear resection not very useful. And I will say that I have done maybe 2 or 3 lateral ear resections in dogs in my entire career, and I've done about 400 or 500 total ear canal ablations. So my opinion is that if they're bad enough to need a lateral ear resection, you're probably looking at a total ear canal ablation. And Gemma says, feel that medication options are more effective these days too than previously, and so uncommonly to have to do a lateral ear canal resection. So great to have all those comments, and please keep the comments coming. I will try to keep answering them as we go. So total ear canal ablation, one thing to consider is that if it's unilateral disease and very rapidly progressive, you definitely need to consider neoplasia as a possibility, because this is a chronic disease. It's not something, or quite chronic. It's not something that should progress very, very rapidly. And so you definitely want to consider neoplasia by doing a good otoscopic examination. Remember that the ear canal is just an invagination of the skin, and so you need to consider a total dermatological examination as well. And then also, when you're examining these patients before surgery, you want to do a neurological examination to look at things like facial nerve palsy, vestibular symptoms, and how well they can hear. 2 reasons for that. Number one is if you have vestibular symptoms, that's going to tell us definitively that we have otitis media, at least, and going towards otitis interna. If you have facial nerve palsy, that tells you that you have a lot of disease outside of the ear canal that's causing inflammation and compression of the facial nerve. The other thing that you want to know is if the dog wakes up and has no facial nerve function, was that your fault or was it already present beforehand? And then hearing, a lot of these dogs that have really severe ear canal disease, their hearing is pretty poor to start with. So, and so often they can't hear anyway. Just have another comment here. So just a comment that English Cocker Spaniels always get bad ear infections. Yeah, so I would agree with that. With total ear canal ablation, you're looking at complete resolution of clinical signs in about 93% of dogs. So with the total ear canal ablation, basically what we're doing is we're taking out the entire ear canal and right down onto the bulla, and then in addition to taking out the ear canal, you have to do a bull osteotomy. The reason is that if you leave the bulla intact, you're going to leave secretory tissue in there, which is going to cause draining tracts and continued pain and infection, abscessation, and that kind of thing. So My analogy when I'm doing a total ear canal ablation is that you can't have a headache if you don't have a head. So basically we're just eliminating the entire problem. So looking at the canine ear, there are a few structures, actually there are a lot of structures that you want to be aware of when you're doing total ear canal ablations. And this is one where when I teach these laboratories, I go up and ask each station to point out the relevant anatomy before I get them to go forward and do the procedure, because it's so important, and there's so many important things that you can damage that you want to make sure you know what you're doing. So if you're thinking about doing total ear canal ablations or salivary gland extirpations, I'd strongly recommend that that you do cadaver surgeries on a few patients, or at least one patient, both sides, both the salivary glands and the ear canal, so that you can get some experience with the anatomy. There's a question here, would you usually do a CT scan before or pre-op? I would love to do a CT scan on all of these. The fact is that before I had my own CT scanner, I did a lot of these without a CT scan, and the things that would tell me that I don't need a CT scan would be if I have very chronic disease that's bilateral, it's probably not going to be a tumor. The main reason why I'm doing a CT scan beforehand is to see if there's evidence of neoplasia, bony lysis, that kind of thing. And so I'm happy to do them without a CT, but if we have that option available, that would be preferable. Now looking at the anatomy here, we have the vertical ear canal here, the horizontal ear canal here, and then the tympanic bulla is here, and the eardrum acts like literally a skin on a conga drum, and so that air-filled space and that skin gets reverberated through the ossicles and into the cochlea, and that's what gives you hearing. Note that the semicircular canals are up here dorsal to the tympanic bulla, just behind or just medial to the eardrum. So really important anatomy to be aware of. All right, so here's some more anatomy that we're going to look at. So the tympanic bulla, or the ear canal, is sitting right here, and wrapping right around the ear canal we have this facial nerve here. So that's really important when we're considering doing surgery. Facial nerve palsy is, as we all know, the most common complication of total ear canal ablation. So facial nerve coming out right here, coming out of the stylomastoid foramen. Note that, and this is going to be more important for the salivary gland extirpation, but we have the jugular vein here coming up into the maxillary vein and the linguofacial vein down here, and then the salivary gland sits right in the bifurcation of the jugular vein right there. So this is the first step in a total ear canal ablation, where we make a skin incision around the outside. I'll make that green so you can see it, on the outside of the ear canal, and then we make a vertical incision over the vertical part of the ear canal. So get rid of that. So just to review, circumferential incision on the external ear canal, and then vertical incision over the vertical ear canal. And then the next thing that we do is we dissect down down to the cartilage on all the way around, circumferentially around the ear canal. And this is the most important part in order to try to avoid facial nerve damage, is to dissect right down onto the cartilage. You want to get every bit of soft tissue off that cartilage. Just going to look over and see, there's another comment. Would just a radiograph be helpful as well before surgery if CT is not available? So yes, radiographs can be helpful. That can show you, number one, that you have thickening of the bulla. It can show you if you have fluid within the bulla, which is going to tell you definitively that you're going to have to do that bulla osteotomy. You have to do it anyway, but it's going to tell you what to expect when you get in there. And so if you had bone destruction, if you have fluid in the bulla, that's really important. And also you can see calcification of the external ear canal, which is going to tell you a little bit more about chronicity of the condition. So once we've amputated the ear canal, we're looking into the bulla right here. And so the facial nerve is going to be coming out right here. So this is caudal, stylomastoid foramen there, and then the facial nerve is wrapping around the ear canal right there. And so you cannot stop here. You have to then remove the ventral portion of the bulla in order to make sure that you're getting rid of all that secretory material. So this is a close-up of the ear canal. So this is the external acoustic meatus, which is where the ear canal comes in here. Eustachian tube attaches to the auditory tube right there. Tympanic bulla, and then the tympanic membrane is sitting right here. And our semicircular canals, which are responsible for balance, are sitting right up here. All right, so when we've done our external ear canal removal, and then that's the bulla opening there, and this is where we've opened up the tympanic bulla. And I like to take out even more than that. So I like to leave it wide open down here just to make absolutely sure that I can remove all of that secretory material. And this is what they look like when we're finished. So we've got the vertical part of the incision right here, horizontal part of the incision right there. So regarding complications with total ear canal ablations, there are a lot of them. Luckily, a lot of them are not catastrophic, but they do occur commonly. And so I like to divide them up into intraoperative, early postoperative, and long-term postoperative complications. And I'll briefly go through a video here. Let's see if I can click on this. So this is from our YouTube channel. I'm sure that most of you are familiar with it since you're watching this video. So just coming along here. All right, so I'm making my circumferential incision around the ear canal, and then I've made my vertical incision over the vertical ear canal as well. And it really helps to have an assistant turning that ear canal inside out so you can make that circumferential incision. All right, so moving along, hold on just a second. Moving along here. Now, one thing that I find helpful is to grab onto that ear canal using towel clamps, and then have an assistant pull or almost try to avulse that ear canal out so that you can more clearly see the soft tissue attachments. And then I'm happy to use electric cautery until I get to the point, the demarcation between the vertical and horizontal ear canals. Once I get to a horizontal ear canal, I'm going to go strictly with sharp and blunt dissection and not electric cautery, because I don't want to damage that facial nerve. Just trying to advance the, sorry. Just trying to advance the video here. It's not letting me. I was able to do it before. Here we go. All right, so dissecting further, and I'm just being really careful with those Metzenbaum scissors, dissecting all of the soft tissue, and then just using pinpoint electric cautery, and you can see that glistening cartilage that I've gotten down to, and that's the way to avoid damage to the facial nerve, is by really carefully dissecting that soft tissue off the ear canal. So advance a little bit further here. So again, using that towel clamp to pull on the ear canal, and then I'm really carefully coming in. Sorry that you can't see because my big fat fingers are in the way, but dissecting down with Metzenbaum scissors, and just being really, really careful to get right down onto that auricular cartilage. Trying to see if I can identify exactly the point at which we transected the ear canal. I'm just dissecting right down onto the bulla there, holding on to the external ear canal. Questions, let's see. In brachycephalic breeds, a drain is advisable. What is your opinion? I don't use a drain in any of these. If I've got a big abscess, with abscess surrounding the ear canal, I might use a drain, but it's very rare. Worst case scenario, if you cut the facial nerve, they have facial nerve palsy and they can't blink in that eye. If it's not a brachycephalic dog, it's usually not a big deal. If it is a brachycephalic dog, then sometimes you have to do a tarsorrhaphy in order to prevent them from getting keratoconjunctivitis sicca. And question, are we doing... and if you damage the semicircular canals, that is devastating because they have a really, really bad head tilt, and that head tilt can last a lifetime. And so when I'm doing these and dissecting, I stay far away from the dorsal aspect of the tympanic bulla. We do antibiotics intraoperatively and then anti-inflammatories and pain medications postoperatively. And the pain medication that we would use, we would do a mepivacaine splash block into the incision, and then afterward we would use methadone for the first 24 hours after surgery, generally send them home with a fentanyl patch. So you can see here that I'm transecting the ear canal right now at the level of the tympanic bulla. You can see a branch of the facial nerve extending caudally just above my Metzenbaum scissors. I can't point to it because it's on the video. But here we are transecting the ear canal there, and then we'll be looking right down into the tympanic bulla. All right, and then at this point, I'm using rongeurs. That's actually a pretty good view. You can see down into the tympanic bulla, and there's soft tissue in the bulla. And so I'm going in with rongeurs and putting in one branch of the rongeur, one limb of the rongeur in the tympanic bulla and the other one ventral. And then I'm just chipping away that bone, and I want to remove about the ventral 30% of the tympanic bulla. And there's the facial nerve up there I just pointed at with my rongeur. And you can see that ventral thickened wall. You want to stay away from the rostral margin of the tympanic bulla as well, because there's a large branch of the internal carotid artery there, and I've never had it happen myself, but I have heard of dogs bleeding to death as a result of this procedure. So staying away from the rostralmost portion of the tympanic bulla. Sorry, just trying to grab onto this so I can move forward. And then the next thing that I'm doing is I'm reaching in with suction and with a curette in order to remove every bit of the soft tissue that's inside that tympanic bulla. Because if you leave any secretory material, you can have draining tracts that can form and abscess formation. And I've had that happen in a couple of cases. If I've done 500 of these, I've probably had it happen in about 5, so that's a 1%. It is reported as high as 15%. I think that's an ossicle right there. That's one of your auditory ossicles. I think my rate of fistulous tract formation is low because I am so careful, number one, about removing a large portion of the ventral aspect of the tympanic bulla, and then I also am very careful to spend a lot of time cleaning out all the soft tissue from the inside of the bulla. All right, so when we're finished with that, we flush, and then we do a splash block, and then we just do a closure, close it in a T incision. Some people eliminate or don't do the vertical part of the incision, just do the circumferential. I just find it a lot easier to get that exposure by doing both the circumferential incision and the vertical part of the incision over the vertical ear canal. Question about difference between cats and dogs. I do have some slides that I'll go over in just a minute that'll explain the difference between the two. All right, so I'll leave that there, move back to the lecture. All right, so intraoperatively, one of the big complications that we can get is hemorrhage. And again, I have seen or have heard of dogs bleeding to death during this procedure. So looking here, I'll just draw a little blue circle. That's the opening of the bulla right there. I'll use yellow. This is the facial nerve coming out here. This is an anatomic specimen, so that's been transected. The bulla is sitting right down here. And then right here we have the maxillary artery, and then this is caudal back here, and this is cranial, And so this branch, there's a branch coming up right here of the internal carotid artery that if you pick that off, you know it. And the problem is that it's coming out of a bony tunnel, so you can't even cauterize it properly. So that is a very annoying complication, and you want to avoid it if you can. And so when I'm doing, let's say this is the tympanic bulla right here. Dorsally, we have the semicircular canal, so we want to avoid that. Caudally, we have the facial nerve right here, and then rostrally down here, we have the internal carotid artery. So those are the things that you want to avoid as you're going in. Another question from, let's see, from Payush. In cats, do you prefer ventral bull osteotomy? So that's a really good question. If all you have is otitis media and otitis interna due to, say, for example, a polyp, then just a ventral bull osteotomy is the correct way to go. However, in cats, if you have otitis externa, which is less common than it is in dogs, or if you have a ceruminous gland adenocarcinoma or squamous cell carcinoma in cats, you have to do a total ear canal ablation, lateral bull osteotomy. Question from John. Curating, do you want to remove all the soft tissue, but you want to stay away from the dorsum of the bulla to avoid the semicircular canal? So how far dorsally do you go? Great question. There is a recess dorsally that you want to stay out of. And so if you're looking up here, so that the semicircular canals are going to be right up in here, and they're actually up in a recess. And so you can work in all of this area with impedance, confidently that you're not going to do any damage with your curette. Usually there's a recess deep to that maxillary artery that comes up in here, and that's where a lot of kind of up in here, that's where a lot of the soft tissue sits. So just totally avoid that little dorsal recess right there. And then another question, hi from Algeria. What is the benefit of cropping the bulla if you do not place a drain? So I'm not sure I understand the question, but you have to do a bull osteotomy if you're doing a total ear canal ablation. Otherwise, there's no way for all that secretory material to exit. So if you're doing a total ear canal ablation, you must do a lateral bull osteotomy. No question about it. All right, so facial nerve severing is an intraoperative complication that I have seen a couple of times. I've actually found when I finish my removal of the ear canal that I'm looking at a cross-section of the facial nerve. It's upsetting, but it's not like horribly catastrophic. And the way to avoid that is to stay really, really close to the ear canal and the cartilage as you're dissecting down, and so that you avoid the soft tissue in which the facial nerve might be encased. Early postoperative, you can see incisional infections. I've seen pinna necrosis occur in a cat that had diabetes, and so I think that its blood supply was poor. And then we've got this series of neurologic symptoms. Vestibular signs would be if you damage those vestibular canals, the semicircular canals dorsal. Facial nerve palsy, obviously, if you damage the facial nerve. I'd say the risk of vestibular nerve or vestibular signs after this procedure is probably about 5%, maybe not even that much. I've had it happen in 2 animals that I'm aware of. You never forget it because they're really, really miserable. They have really terrible nystagmus, head tilt, they can hardly stand up. Facial nerve palsy you're going to see in about 60% of dogs early on and about 10% permanently. So 60% temporary, 10% permanent. And the temporary ones are probably due to retraction of the facial nerve with Gelpi retractors. And then Horner syndrome, in cats you're going to see it almost every time because the sympathetic trunk sits right on the promontory, which is the demarcation between the ventromedial and dorsolateral chambers of the tympanic bulla. Another question here, sometimes we get infection at level of bulla, but mainly abscesses after 2 to 3 months. Did you have any? Yeah, so that's exactly correct. That often what you see is either draining tract formation or an abscess that forms 2, 3, 4 months down the road. So probably in 2 of my 5, I had fissulous tracts form, and then in the other 3 I saw an abscess form and just really severe pain on opening of the mouth and that sort of thing. So about how much deeper than the facial nerve do you find the bulla? The facial nerve is probably about 3 millimeters superficial to the opening of the bulla. Any peculiarities when it comes to cholesteatoma cases, I'm not sure that I've seen one, or I might be calling it something different. I'm sorry that I don't have any information on that for you. And then late postoperative deafness, there's some question as to whether they could hear in the first place. There are two papers that came out at the same time. Both of them did brain auditory or evoked responses to see if they had hearing after surgery compared to before surgery. One of them found that they could hear after surgery. The other one found that they could not. I think what we hear, or what we find, is that these dogs can hear loud noises and can feel vibrations. And that's generally what we see clinically. And then the last one is the recurrent draining tracts that we've already touched on. Questions about any tips to protect the facial nerve. The key tip is just to dissect. So I'll draw it again. When we've got that ear canal, we want to, so say all of this is soft tissue surrounding the ear canal, you want to dissect right down onto the cartilage of the ear canal the whole way down. That's the way to avoid the facial nerve, because the facial nerve is going to be in this tissue out here. And so if you come like this with your scalpel, you're going to cut the facial nerve. You have to come like this so that you leave the facial nerve intact. All right, so this is a CAT CT. And so this is what I was talking about before. There's a demarcation. So this is the ventral medial compartment, and this is the dorsal lateral compartment. Sympathetic trunk sits right on the septum between the two. And if you only do a total ear canal ablation and go into the dorsal lateral compartment, you're going to leave all that secretory material behind. And so you have to make sure that you penetrate through that septum and into the ventral medial compartment. And then this is the feline one again. There's a vestibular window sitting here. This is the septum bulli. And then this is the ventromedial compartment and the dorsolateral compartment up there. And that's the promontory, and that's where the sympathetic trunk sits. All right, changing gears. Any questions about total ear canal ablations? I'm just watching the computer now. I don't see anything. All right, so say we get this Rhodesian ridgeback that comes in with a large swelling on the ventral neck. There are several different things that it could be, and I want you to think, and I want you to put in the chat comments what different or differential diagnoses would be for this. So let's see what we've got here. Start listing differential diagnoses for a large ventral cervical swelling in a dog. Anybody? I think you may be lagging behind me by a couple of seconds. All right, so the first one that I would think about would be salivary mucocele. Thyroid carcinoma is another one to consider. Enlarged mandibular lymph nodes, so lymph node, salivary gland, cellulitis. John, I think you've been to one of my lectures before. There's a question from Total Ear Canal Ablation. In the case of ceruminous gland adenocarcinoma in cats, if it doesn't extend to the bulla, would you be advised to do a TECA bow or TECA with just scraping off the bulla with curette? I would do a full TECA bow, no question about it. So abscess foreign body. So you guys have listed on the chat all of the differentials that we would be thinking about. So abscess foreign body, we've definitely seen in this area. Enlarged mandibular lymph node, which would be commonly seen with lymphoma, salivary mucocele, thyroid carcinoma. All right, so what's the first thing that we're going to do? Well, a couple of things that we're going to look at would be demographics and history. If it's less than 7 years of age, it's generally unlikely to be a thyroid carcinoma. Usually we see those kind of 8, 9, 10 years of age. If it's an apident, you might think about an abscess. If it's in respiratory distress, you could think about a pharyngeal mucocele or potentially a thyroid carcinoma that's damaged the recurrent laryngeal nerve or compress the trachea or something like that. All right, what's our next diagnostic test? Is going to be to palpate it. When we palpate it, if it's fluctuant, we're going to be thinking of things like salivary mucocele and abscess, and if it's hard, we're going to be thinking of things like thyroid carcinoma and an enlarged lymph node. Okay, so palpation is your first diagnostic test that you're going to do. Then what's the next thing? All right, so if it's solid, again, we're thinking about if it's a solid mass and it's cranial, closer to the mandible, up in here, we're going to be thinking about a lymph node, whereas if it's caudal, we're going to be thinking more of thyroid carcinoma. All right, so those are general rules, and thyroid carcinomas can occur anywhere in the neck or even in the thorax, but generally, if it's really far cranial or really far rostral, you're going to be thinking about lymph node, and if it's farther caudal, you're going to be thinking about thyroid carcinoma. And then we aspirate it. So if you aspirate it and you get saliva, clearly it's a salivary mucocele. If you get blood, we're thinking about thyroid carcinoma. And if you get immature lymphocytes, look, I'm not a great clinical pathologist, but you'd be thinking about potentially lymphoma. I wouldn't be happy diagnosing lymphoma by myself. You could get an idea if you saw these huge lymphoblasts, but I would still want to send it off to a clinical pathologist. If you have blood, when you aspirate a thyroid carcinoma, generally all you get is blood. Occasionally you'll see some carcinoma cells as well. And then saliva. And remember that saliva can look like pus can look like saliva. And so if there's any question about whether it's pus or saliva, look at it under a microscope, look for all those neutrophils. If it's a salivary mucocele, it's really important to determine which side is affected, because we're only going to want to remove one set of salivary glands. And so there are a few different ways that you can try to figure out which side is affected. The first one, or the easiest one, is to ask which side it started on, because often they'll start off on one side and then kind of gravitate to the middle. So the side that's affected is usually going to be the side that it started on. The other thing that we'll do is we'll lay them on their back and see which side it falls to. So generally it's going to fall to the side that's affected. If you look under the tongue and see a ranula on one side, that's usually going to be the side that's affected. And then the next thing we can do is imaging in the form of a CT scan. So this is a dog that had a CT scan, and we can see all of this saliva extending right down along the lingual duct all the way down to the papilla where it comes out from under the tongue. So this was a right-sided salivary mucocele. So clinically, this is what they can look like. Generally, they're fairly fluctuant, soft, non-painful. When we see them, often they're recurrent, which means that they've been aspirated previously and then they come back. And so that's fairly typical.
Question, as the formation of abscess is likely in a few cases, why or why not putting a drain would be an option?
So if you had an abscess in that location, my first consideration would be that there's a foreign body in there, and so I'm going to explore it. If I explored a dog and did not find a grass seed or a stick or a twig or something like that, really could not identify the location of it, I would flush it out really well and then close it primarily, put them on antibiotics. I still probably wouldn't put a drain in it. I think that drains are really, really overused. Those of you who watch my live streams know how I feel about drains. If I am going to use a drain, it's going to be a closed suction Jackson Pratt drain, not a Penrose drain. So here's a ranula sitting right here, and that's going to be ipsilateral, so on the same side as the salivary mucocele. What are our treatment options? If you have a ranula, you can try to marsupialize it, but in my opinion, that is fairly ineffective, and so it may help the problem initially, but what's going to happen is that's going to heal over and it's going to recur. Are there any questions or any comments from anybody that has done ranula marsupialization and had it work? Generally, when I ask this question, most people tell me is that it works initially, but then it recurs pretty quickly. And then the next or definitive treatment is salivary gland extirpation. So going back to our anatomy lesson here, really, really important to review our anatomy. So we're looking at jugular vein sitting here, maxillary vein, linguofacial, facial vein up here, lingual vein down there, and then the salivary gland is going to be sitting right in the bifurcation of the two big maxillary in-linguofacial veins. Looking over here, we see the mandibular salivary gland, and then the monostomatic portion of the sublingual gland and the polystomatic portion of the sublingual gland. So mandibular salivary gland, monostomatic sublingual, polystomatic sublingual. And then really importantly here is where the lingual nerve crosses the salivary duct, because that's how far rostrally we're going to want to dissect before we transect it and ligate it. Other thing that's important here is the hypoglossal nerve sitting right there, and that you will see that in your field, and you do want to see, you do want to look out for that and not cut it. Question about seeing ranula occurring in cats. I don't think I don't think I've ever seen one in a cat before. Have you? I'm interested to hear your comments there. All right, so our initial dissection here, I've made an incision. I have the dog in dorsal lateral recumbency. So, and this is the mandibular salivary gland sitting here. Remember that our maxillary vein is here, linguofacial vein is right there. Now, when you're dissecting these out, you do have to pass the duct underneath the digastricus muscle. So this is ventral. Let me write this down. Ventral down here, and dorsal up here, and then this is the digastricus muscle right there. And we're going to have to pass that mandibular salivary gland, either the whole gland or just the duct with the monostomatic portion of the sublingual gland underneath the digastricus muscle so that we can complete our dissection rostrally here. And so here is the salivary duct sitting right there. And then here's a video of the surgery. So again, this is from our YouTube channel. Let me just go back to the beginning here. All right, so there's our salivary mucocele here, and unfortunately, because it's a YouTube video, I can't point to anything, but I can explain to you as we're going, and I'll try to pause it and try to explain it. So moving forward here. All right, so I've made my initial skin incision right at the bifurcation of the jugular vein into the maxillary and linguofacial veins. And then use Gelpi retractors. Really can't do these without Gelpis. Okay, and so where my finger is right there, that's where I can feel the mandibular salivary gland. So dissecting further along, and caudally there, right underneath my, so I'll stop it right there, right underneath my electric cautery pen is the mandibular salivary gland, sitting right there. So I'm using electric cautery to define that. And you do not, the salivary mucocele is non-secretory. The lining is non-secretory, and so you do not need to amputate the whole lining. All you need to do is take out that salivary gland. And up is dorsal, down is ventral. And that's the salivary mucocele right there, that purple that's just in front of, or to the right of the mandibular salivary gland. There is a blood vessel. So just some more dissection around that, and that's heading up over the digastricus muscle. So that's the salivary duct right there. If I wasn't careful, I could have easily transected that inadvertently. Sorry about my big head. And the bright lights. All right, so I've grabbed on to the salivary duct, and then I'm sitting right on top of the digastricus muscle there. And just dissecting really carefully using my electric cautery. I usually turn my cautery down to about 20 at this point. Make sure that I'm not going to inadvertently transect. Now I'm putting my finger over the digastricus muscle there, right over the top there, and I'm going to pass the duct underneath the digastricus muscle. So now I'm just clearing out the path for it a little bit ventral to the digastricus muscle there, just dissecting through that salivary sialocele tissue. So that's digastricus on top there. So I'm going to put my Gelpi underneath, kind of between the digastricus muscle and the lining of the salivary mucocele. And then just dissect a little bit farther rostral here. And then my hypoglossal nerve is going to be right where deep to where my electric cautery is. Just a lot of blunt dissection with my finger. The myoglossus muscle is down there. That's all the lining of the salivary mucocele. You do not need to amputate that. Just opening it up so I can see, but I don't need to take out that lining.
Question here from Sonura. 5-year-old cat with sublingual flocculent swelling. Aspirate was viscous and stringy like saliva. Marsupialization failed almost immediately, but awaiting histopath at the moment. Yeah, so that's likely to be a salivary mucocele, and you'll have to take out that mandibular salivary gland along with the sublingual gland. So I'm suctioning out the saliva here. Let's see if I can advance this a little bit forward. I'm just opening things up there so I can see a little better. Hypoglossal nerve is going to be right there. All right, and now I'm going to pass it underneath the digastricus muscle. And then just grab it on the other side. And then re-grabbing. And then what we're going to do is we're going to dissect rostrally to the level of the lingual nerve. And then we'll transect and ligate it. So question about how hard is it to do a revision surgery if the primary surgery is incomplete? Generally, if you have recurrence of the salivary mucocele, it's because you went in on the wrong side. And I have had that happen before. I've never seen it recur just because we left a little bit of sublingual gland there. Generally, you have to go in and take out the other side. And dogs have plenty of salivary glands, and so you won't have any issue with xerostomia if you go in and remove the other salivary gland. Question about the electric cautery and turning it down to 20 around the digastricus muscle. Look, you'd probably be better off turning it down to 20 at the beginning of the surgery once you get past the skin incision. Depends on how confident you are with the anatomy, and every cautery machine is going to be different as well. They're not going to all behave the same with the same settings. So here I am dissecting rostrally until I find the lingual nerve, and all that kind of oozing gelatinous stuff, that's all saliva. And that's the lingual nerve sitting right there. I don't know if you guys can see it, and I'm sorry that I cannot point it out. Remember that these videos are available on YouTube, and
I don't have the sound on right now, but I am narrating the whole time as I'm dissecting, so you can get a good review of that as well. So those are some more of the polystomatic glands. And that's the duct sitting right there. And the lingual nerve is right there between the Gelpies. Right there. So just dissect it up to there, and then we will put a right angle forcep on it, ligate it, and transect it. There's a question about how necessary it is to do the digastric dissection. I think that, in my opinion, if you don't pass it underneath the digastricus, you're going to leave about 5 to 8 centimeters of salivary gland and duct in the dog, and so my preference is to always do that. I have never done it without doing that. I've heard of other people doing it where they just basically avulse it and pull until they've gotten enough out and then transect and ligate it. But I can do a much better job getting all the way up to that lingual nerve, which I'm dissecting around right there, if I pass it underneath the digastricus muscle. All right, so that's pretty much it for that procedure. Go back to my lecture. So question about, we don't transect the lingual nerve. I'm sorry, if I said that, I misspoke. You leave the lingual nerve alone. You want to be really careful for that. I really apologize if I misspoke. What we're doing is we're transecting the lingual duct, the sublingual duct, not the lingual nerve. Again, stupid mistake on my part saying that. That is absolutely incorrect. You are just dissecting down to the level of the lingual nerve and then transecting the duct itself. So I think that that's the end of my lecture. That's about it. So I'll just stay on for a minute to see if you have any further questions, but that's pretty much it for my lecture. I hope you enjoyed it. If you have any questions, you can post them after the lecture, and I'm happy to answer them when I can. And if you have any ideas for other lectures that you'd like to see us do, especially now that we can't do lectures in the Rivoli anymore because of coronavirus. So I hope everybody's doing well and surviving and staying busy, not too bored in quarantine if that's what you have to do in your country. We are not quite to the point that we are totally isolated, but we're supposed to be staying in our houses and not doing any unnecessary activities outside. We're hoping that they're going to say that veterinary practices are essential businesses so that we don't have to close down, but we're all just sitting around waiting because nobody knows really what's going to happen. And so I think the next 3 or 4 months are going to be really interesting. And it's a great pleasure. Thanks everybody for watching. If you haven't already done so, please subscribe to our channel. And don't forget to turn on notifications so the next time we live stream, you'll get a ding on your phone and you can stop whatever you're doing, particularly if you're in quarantine and really bored, and you'll be able to watch some nice surgery. And usually I throw in a couple of good dad jokes. So hope everybody's okay, and I will talk to you soon. Thanks again, and we'll see you later.